Well, good morning, everyone. Perhaps we should go ahead and get started. I think it's 7:30. My name is Cindy Howard. I am the director of the Global Pediatrics Program. On behalf of Global Pediatrics and also the Division of Hematology and Oncology, it's my privilege to introduce Dr. Scott Howard. To our knowledge, we're not related, maybe somewhere way back. Dr. Howard is professor and also Associate Dean of Research in the College of Nursing at the University of Tennessee, Memphis. Early on in his medical education, Dr. Howard became interested in global health. Following his training in adult and pediatric medicine, he completed a master's in epidemiology and a fellowship in hematology and oncology at St. Jude's Children's Research Hospital. Today, his research with international collaborators focuses on implementing advanced practice nursing to build critical workforce capacity and improve subspecialty care for children with cancer in low and middle-income countries. He has published close to 200 articles. Dr. Howard's presentation entitled Next Steps in Pediatric Global Oncology is of personal interest to me, not only because my academic focus is in global child health, but also because of my experience as a young pediatrician stationed with the U.S. Army in West Berlin, East Germany, the year after my residency. From there, I accompanied my 6-year-old patient, Christian, and his father first on a DC-9 and then on a C-130 to the United States. Christian arrived on the pediatric ward at Walter Reed Medical Center within 24 hours of his diagnosis of acute leukemia. I stayed in touch with Christian's family until he graduated from high school and went on to college. 7 years later, I took care of another little boy with the same diagnosis, whose name was Yinka. I was practicing in the savannah of Nigeria. The year was 1991. Most 8-year-olds with a diagnosis of acute leukemia in high-income countries had a good prognosis, but adequate chemotherapy and antibiotics were not available in Nigeria. Yinka never went into remission. I was with him when he died at home in his village. I have not forgotten these little boys, and that one had the most powerful air force in the world at his command, while another little boy had none of even the most basic drugs. Dr. Howard's research focuses on this ongoing disparity in the care of children with cancer in the majority world. Please welcome Dr. Scott Howard from the University of Tennessee.
Well, thank you very much for having me. Thank you, Cindy, for coming to the airport and for hosting us at your house. And I really appreciate you all coming this morning. I hope to convince you of a couple of things, but really just one thing, which is that systems are better than goals. And I know not all of you are pediatric oncologists, and nobody's perfect. Right? So I was thinking the systems that can be applied to every field of healthcare and actually every field of life. So I'm really glad you came. I have disclosures here, and I also love how it's called disclosures instead of conflicts of interest, because I think, well, I'm CMO of this informatics education and consulting company, but the reason I established that company was because everywhere I ever went that wanted to work on improving care in low and middle income countries lacked information systems. And then when you go to buy an information system, they cost hundreds of thousands of dollars. And the total chemo for a child with acute lymphoblastic leukemia, like those two that Cindy just mentioned, the total cost of that is about $1,000 US. All cheap generic drugs from the 50s, 60s, and 70s can cure 90% of children with ALL in every country, well, not in every country, but in countries with adequate supportive care. So if you want to spend $100,000 on informatics, you could have paid for the chemo of 100 children, which means the informatics has to be free. So that's why that company is there. And so I would call this, I guess, a convergence of interests, but I'm disclosing it anyway. And then these are companies that have done business with resonance. I'm also a great promoter of two authors, Scott Adams, who writes the Dilbert cartoon. And have any of you ever read one of his actual books? Not the cartoon, but the book. Say yes or say no. Measuring the non-response rate. So if half of us are already asleep, this is not good. And I'm highly influenced by relationships. And I tell you that because I was really happy to learn of some of your work doing here. And I will now tell you my first system. So systems better than goals. A goal would be to have a good photograph when you're at a social event. A system would be to take about 25 photographs every time you take a photograph, because this was one of the best out of 25. There were 23 grossly blurry. There was one where a couple of the facial expressions were non-flattering. So the system works, right? You take 25, look at these beautiful people. So the other thing about relationships is you never know what's going to happen. So you guys might know Sharmila. I met her in Cairo, Egypt, actually. And we talked for a while, and then she said, you know, you should come to Minnesota, and then here we are. So thank you, Sharmila. She's in Bangalore today. So thank you. I don't know which way is Bangalore, but I should ask you also, do you think the white background is better or the blue? A or B? All right, who says B? Who says A? Good point. Who says it depends on the other content? Oh, okay. How about, okay, A or B? A. B. C. What would C be? Less text. So there's only one message here. Systems are better than goals. But the subtext is, one system would be to integrate continuous quality improvement into daily practice so that we're helping every patient while we're helping each individual patient. A second system would be to focus on one or two issues that each of us can personally and feasibly influence in, say, this period of time. So my own life is divided into 5-year segments, and during that 5 years, I think, what could I do during this period that would have the most impact and make the most difference? A system would be to involve everyone and to publish the results so that everyone benefits. And a system would be to actively fight pride and selfishness, which seems like it should not be in a medical talk, but I'm going to tell you why it belongs here. Another system would be to have 2 slides in case you said this was better. So I'm not sure, but I was told by a reliable source that this is old school. And then I was told by the experts, no, it's better to have a dark background and white text. So who would you believe? A reliable source, which happened to be my wife, or the experts? Or the survey, so A or B? Okay, so she's right again. And I thought you'd say that because she's usually right. So all the rest are like this. Systems are better than goals. So here's a book that my first recommendation is How to Fail at Everything and Still Win Big. And this whole book is how to apply systems instead of goals. Because if you apply a goal is I'm going to lose 10 pounds. A system is every day I'm going to exercise. So every day I exercise for 10 minutes, let's say, at least 10 minutes. So then I'm doing my system. Whether I achieve the goal or not, I will achieve the goal accidentally if I do the system. But it means that every day I exercise, I'm a winner. I've achieved my target for today. I've followed my system. As opposed to every day that I'm trying to lose weight, I'm a loser until that 5-pound mark. Then I'm briefly a winner for that 1 minute. And then I probably set a new goal. So I'm a loser again until the next goal is achieved. So the system is better. And one system that this guy did who wrote this book is called social validation. So he got a picture of a pretty lady reading his book, and this makes us think, oh, the cool people, the good-looking people read this book. This must be a good book. So the system is actually called persuasion. And so this guy who wrote this book, Scott Adams, he didn't just write Dilbert. It turns out he's a trained hypnotist. And so during the training to be a hypnotist, you learn about how to influence people, how to watch their breathing, how to understand what they're thinking, how to predict what they're going to do. And so that all the little tricks, you put them together and you can hypnotize them. And so his system was to learn additional talents like hypnosis, like persuasion, like how to write. And he even said when he started drawing the Dilbert cartoon, at first he made beautiful Dilberts. And then he realized he spent days drawing one Dilbert. And he's not going to have days because it's a daily cartoon. So that's why Dilbert is very simple. Like really simple lines, a few colors, a few characters that get repeated over and over. So his system is, don't spend time on the artwork, spend time thinking about the humor. And so that system obviously paid off. It's been going for 30 years now. So a health system is all the organizations, people, and actions whose primary interest or intent is to promote, restore, or maintain health. And that's great that it's a system, right? So we talk about, healthcare coverage. Well, coverage is part of the system. We talk about where should healthcare facilities be. Facilities are part of the system. We talk about training, residents and fellows. Personnel is part of the system. So all of these organizations, people, and activities then are part of a system, and that's why it actually mostly works. So here's your next question. I thank you for your formatting advice. So this is a question, And so then you answer. That's how it works. Question? How about this side of the room? The shy people. Okay, that's good. Other ideas? Move the field forward, right, and it's fun to move the field forward. Great. And provide better care, great. So I'm an oncologist, so maybe I'm biased because I think of saving lives. And yeah, I guess most people don't die of their otitis media. But, you know, my goal number one for the oncology is to save their life. And then, of course, goal number 2 is also to save their life. But I want you to guess, what is goal number 3? Oh my goodness, so good. Yes, improve their life. Right, so that applies to every part of healthcare, right? If we could prevent otitis media, think how many lives would be improved. The lives of the pediatricians would be improved radically. So integrating continuous quality improvement into daily practice. And this idea, I think, is very popular in the US, and it needs to be more popular everywhere to really work. So here's just one example of oncology care in particular. In a high-income country, 100 children might develop cancer, let's say exactly 100, so the math works. 99 will get a diagnosis, 97 will get a correct diagnosis, 96 will have access to care, 95 will not die of toxicity, and then 80% will be cured. So if we look at all the causes of treatment failure, everything that's not dark blue here, relapse is 15% of the failure, and everything else is 5% of the failure. So what do most protocols for childhood cancer in this country focus on? Preventing relapse, which is correct. A secondary objective, though, is to prevent toxicity, late toxicity, so improve life, not just save life, but save life in a way that doesn't lead to permanent toxicity. So relapse and late effects, I would say, are the main research areas. But what about low and middle income countries? Not getting a diagnosis actually is the #1 cause of failure in low and middle income countries. Number 2, well, not number 2, but the second in order chronologically is misdiagnosis, no treatment, abandonment, toxic death, and relapse. So the cure rate is much lower, probably 20 to 25%. Nobody even actually knows the cure rate if you take the average across the whole world, because lack of information is another part of the problem. But if you actually wrote a paper about my cure rates in my country, some people write their paper and they don't count the green or the orange or the red. They only count patients who arrived, got a good diagnosis, had access to care, and had good follow-up. And then they write a paper that says, we cured half the children, the blue divided by the blue plus the purple. And so that would be kind of true, but it would only be true we cured half of this selected group of children. But we cured actually 20% of all the children. Right? So if you read a paper that says 50% for Burkitt lymphoma in Malawi, it's not a lie, it's true. But it's 50% of the ones who got onto that thing and got that paper written about them. It's not 50% of all children. So when I'm talking about the cure rate for purposes of today, I mean actually of the 100 children who get cancer, how many did we save their life? And so preventable deaths, I put in this category all the difference between the low and middle income country versus a high income country. And I used high-income country versus low- and middle-income country because that's defined by the World Bank. So it's very objective. It's just about the money. How much money per capita do people make in that country? And so it's not about developing country or a emerging country or any of those things, because a poor country may be developing, but it may be getting worse, right? Zimbabwe used to be an upper-middle-income country, but many years of dictatorship, it went down and down and down. So their health is actually much worse than it was 20 years ago. So developing country, that's a terrible idea, because it could be a poor country that's getting worse, a rich country that's getting better, just depends. So low-income country is nice. So if we use this histogram as our visual, and that would be the second tip I picked up from the Dilbert guy, is visual persuasion is much better than conceptual persuasion. And we have an example from politics. So he writes a lot about Donald Trump, and he said when he was watching the Republican debates, I don't know if you remember in 2015, there were as many Republicans then as there are Democrats now. And you couldn't even sort them all out. They had to have 2 debates just to have everybody have a chance on the stage. And he's mentioned in his book that he was watching the debate, and then Trump started speaking, and he actually stood up and walked toward the TV and thought, he's going to win, because he exhibited all the persuasive features that a hypnotist would recognize. So in a sense, the ability to hypnotize your audience. And it has nothing to do with your policies, nothing to do with your party. You could even be switching parties very recently. Totally unrelated. He said, just persuasive ability determines our presidency every time. And we wish it were otherwise, but it's not. And he said, so the system we should develop is to learn to recognize that persuasive ability, to protect ourselves from it, because the car salesman does the same stuff to us. Another component of this is if I give you something, it triggers this sort of primal response to give something back. And I don't know if you've noticed when you go shopping for a car, what do they do first? They try to give you something, right? Yeah, here's a cup of coffee. Here's a popcorn. Here's, a keychain with our logo on it. And it turns out if you give somebody a $1 popcorn, it triggers the exact same reciprocation response as if you gave them something big. The value of the gift is unrelated. Do you guys remember the Hare Krishnas who used to be at the airport? Yeah, and they're on movies now for the young people. But this is a religious group, and they used to have flowers and go to the airport when you were allowed in the airport, and they would say, here's a flower, would you be willing to donate to our cause? And the flowers were inevitably thrown away, and in fact, in some studies, they would go harvest all the thrown away flowers from the trash and then start again. So you didn't even have to waste flowers. They could be immediately recycled. And the reason for that is if you take that flower in your hand, that triggered the response. And research shows why this works. It's built into us as humans, the reciprocation response. So be careful when somebody gives you something, because it is influencing you. And when they do it, it turns out it doesn't even matter if you know it's a trick. Like they're not giving you that flower to improve your marriage. They're giving you the flower so you give them money worth more than the flower. But even though you know that, it doesn't protect you from the influence of that. So why do I tell you this? Because I think step one of a system would be everything you want to convince people to do needs to have a picture. Build a wall. It's visual. You can see that wall. If you said, improve border security, so weak. You can't visualize it. And so build a wall, even though it's crazy, it actually works on us as humans because we think walls are nice. I have a wall in my backyard. It works, keeps the dog in. So it sort of associates with things. So the bad news here is that there are many causes of preventable treatment failure in low and middle income countries. And each cause has many sub-causes. But the good news is every single one of these can be prevented even in low and middle income countries. And there are published strategies for every single issue. So, no diagnosis. Well, what are the pieces of this? Lack of awareness of the patient, the family. So I didn't know to go to a doctor. Healthcare providers. I went to the healthcare provider and they said, don't worry about it. It's an infection. Try some antibiotic. Or I don't have a pathology lab or a blood count or anything, or I can't afford the pathology lab. Beautiful pathology lab, but it costs $300 to have my sample analyzed. Many samples of biopsies of potential cancer get thrown away for lack of money to pay the fee to do the analysis. So that's one of these contributors. But each of these contributors actually has an intervention that have been used at least in one place, usually in many places, that actually work. Misdiagnosis, again, sub-causes and strategies to address each sub-cause. And you could imagine a sub-cause might have sub-causes, right? If you really wanted to dig in and say, I'm going to work on flow cytometry for low and middle income countries. Well, maybe within flow cytometry, there's sub-causes. I don't have a machine. I don't have a service contract. I don't have reagents. I don't have trained personnel. In the case of Myanmar, they have all of those things, but they have a shortage of lab technicians. So the lab technicians have to take night call 2 nights a week, and they have to be off the following morning. So they do a 24-hour shift, and they get the morning off. And only 2 of the lab technicians know how to work the flow cytometry machine and the process. And so if they're on call the night before, it means the next morning there's no flow cytometry. So you could have everything in your hand and not be able to get a flow cytometry result because of something unrelated to flow cytometry, personnel shortage, and disorganized system. Abandonment. So many causes. So no treatment and abandonment I put together as green here, because no treatment is just you never started the treatment. Abandonment is you started and then left early and never came back until the relapse. And so sub-causes and contributors. Relapse, contributors here, and strategies. So gaps in access to essential chemotherapy, for example, or gaps in adherence. What if you have the pill in your hand? It turns out most pills you have to swallow them to get their benefit. Placebo is probably the only one that you don't actually have to swallow. And toxic death, of course. Infection being number 1, 2, 3, 4, 5. So all of these problems. But isn't it wonderful that people all over the world have studied these strategies, have proven these many diverse strategies that work for each of these problems. So we have a big slate of problems. We have a huge panel of strategies that are easily deployed, or not easily, feasibly deployed in every type of country. So focus on one or two issues. Let's just take a second, and I want us each to think about what would be the most important thing we could work on this year to improve the health of our patients here in Minnesota or in our collaborating sites. One or two things. Then I will ask you to share those with the group.
Part of this job I didn't know I'd have to have speaking first. I'd say access to children's mental health programs.
Nice.
I'd say universal health care, but that's a pipe dream. So instead I will say, yeah, I was, that could be the two, but maybe I would say fixed prior authorization.
Everyone's agreeing with this. Is that more important than mental health, or it's a contributor? Other ideas? This is great. I will let you keep thinking. So if you had to pick one or two issues that you, like as an individual, can think about. So mental health, for example, is that something feasible right now today? That could be I think so. Prior authorization? Maybe there is someone here who has influence. No? Because I think if you focus on prior authorization, you could focus on making it more efficient or having less people have to be in the chain of prior authorization. The need for it, I suppose, is out of scope for this room, but the ability to accomplish it better could be in scope, and that could be your year's project, which would help a lot of people. And so in my own case, developing nurse practitioners and access to chemotherapy are the two things I chose for this block of time. And that's why I went to University of Tennessee and joined a College of Nursing, where there are 80 faculty who are mostly advanced practice nurses. And they know how to create an advanced practice nurse because they went through the process themselves, and they had a strong interest to help the rest of the world do that. That's actually my son when he was little. He was very curious and then did not go into science. So academic activity, I think curiosity is a great driver to get started, but it's not usually enough to finish, because how many times have you said, I wonder how we could improve the mental health of cancer survivors? And that difference in wondering versus actually analyzing how to do it and then doing it is a big difference. Thousands of hours of time and usually money and people and other stuff. So that's why I think focusing on one or two things. So here's like relapse, for example. Big problem in high-income countries, big problem in low- and middle-income countries. And I would say unavoidable relapse is the extra relapses. In other words, if this amount of relapse would have happened anywhere, then this is the preventable relapse, the relapse we could already prevent today. In other words, if that child were not in Nigeria but were in Berlin, then this component would not be present. And so abandonment, of course, this is really, really important. The second system, though, is having some information. And if this is the database, how many of you have ever used a database like this? Yeah, so I trained at St. Jude. In my first project at St. Jude, I had to review 980 charts. And these are oncology charts, so they're this thick, like they have usually 5 volumes. So we have the blue volumes, which are the historical ones, and the red volume, the active volume. And so these were patients treated from 10 to 20 years before I was there. And so I had to order these from a warehouse, and you fill out all the numbers. So I filled out the 980 numbers and gave that. And then they arrived in a box, like a pallet, just boxes this high, and stuck them in my office. And it actually filled the office to, I'm not even exaggerating, so I often exaggerate, but I'm not right now. And like about this high, and there was a little crack, so I could slide from the door. The door would open halfway before it hit boxes, and then slide over, and then the computer was there, and boxes. So I started reviewing these, and it turns out these old charts, I discovered a new disease, which has never been described in the literature, and it's called chart lung. And it's like the disease you get in your lungs when you review old paper charts, because the powder from that old paper, and I already had asthma. So I'm thinking of the coal miners, if they already had asthma or they were smokers, thank goodness I have asthma, because probably otherwise I would end up being a smoker, because I always try something once, and apparently that's a bad idea. But if this is the database, it takes one person an entire year to do a project, right? So if this is the database, it takes that same person maybe 6 months. If it's already in the database, you still got to do the rest of the project. And if this is the database, so this is the free database and free medical record that if any of your partners want to use it, it's yours for free, because that's why Resonance was founded, was to give it to people like your partners. And I did have one person who said, no, we've had a bad experience with free software. We have to pay for it. And I said, okay, how much you want to pay? And she said, because if you have free software, people won't support it. And then after a year, they forget about it. And how many of you have had experience that somebody did something for you, and then they graduated med school, and it never could advance? Yes? Yeah, so I've had actually several of those. And it's because it needs to be a system. If it's just a project, that's not the way to do stuff like software, because then people get, if it's good software, they get dependent on it. Then when it goes away, you've actually caused harm, not good. So the system is, you hire programmers in Bangalore, you make a company that's a real IT company that stores its data in a HIPAA-compliant Amazon cloud that has penetration testing where you hire the hackers each year to try to hack you and certify your weaknesses and strengths, and all that stuff you would do if you're an IT company that your medical student would not do when they design your data entry screen. Because they just don't, it's beyond the scope of what a medical student should do. The other thing that I think is really important is if you have information to be able to quickly get to the statistical part without a great knowledge of statistics. And when I first showed this to a friend who's a statistician, he said, you are making a terrible mistake. You are going to hurt people. This is like giving a machine gun to a 2-year-old. And I thought, I never thought of statistics as being that dangerous. But he said, if they just go pushing a button, they don't know what it means. And I thought about that. This was 10 years ago that I had that advice, which I didn't take up. Because I thought, well, no, 2-year-olds probably could be taught how to use the machine gun if they knew how to use it right, for the right reasons and the right context. But I was thinking, instead, what we could do is actually build in quality tools. So when you click this button, there's a second report, which I didn't show you, which is every patient who is not included in the survival curve because they have insufficient data. And you can click on that patient, and it opens their thing and shows you the insufficient data, and you can then fill it in and save it. And so the data manager in Morocco was out having her baby, and she came back 4 months later, and the way they have it set up, the secretary puts in all the demographics, and the data manager puts in the cancer-specific information. So the secretary doesn't need special training about, how to use the system. They're just typing into, they used to put it in Excel, now they put it into the system. So when she came back, there were 400 patients who had the red X's of missing data. And said, oh, this is so depressing, I've got 400 red X's. And then 2 weeks later, we have a meeting every 2 weeks. Said, only 300 X's left. 200, 150. So then she was systematically eliminating those data problems, missing data or erroneous data, and feeling very happy about it. And that is a system. Reward people for doing it right. Let people audit themselves. I'm not an auditor of their data. It's their data for their use, for their patients to improve their outcomes. So they have to audit themselves. If they want quality, they have to be in charge of quality, not me. I can also push the button if it happens to be someone who has shared their data with me, but they have to actively share it, and most people choose not to, and that is okay. So here's just an example of 4 different projects or programs in 4 countries. So Ho Chi Minh City, what was their big problem? What would you have worked on if you were there? If you could only work on one thing, in 2006. Yeah, lack of diagnosis, the red. And in fact, they did work on it and got it much lower. If you were in Mali and were working on eye cancer, retinoblastoma, and here's your problem, what would you work on? Everything, but yeah. Well, if you could only work on one thing, if you had a genie that gave you one wish. Yeah, lack of diagnosis, the red. How about you're in Paraguay working on acute lymphoblastic leukemia? Here's your 2006 data. Green, access to therapy, abandonment, and access to treatment. And relapse, of course, but remember, a lot of that relapse is not preventable because it happens in high-income countries too. What about Burkitt lymphoma in Tanzania? I'm seeing a green problem, right? Lack of access. So lack of diagnosis, here's if 50% of children are diagnosed, it's red. All the darker colors are mean less than 50%. So, every map of this kind always shows problems in Africa, and that's why. Go ask the World Bank why. No money. But also, a history of no money for a long time, which means few personnel, few equipment, few infrastructure, few community health workers, insufficient everything. And so you could say, well, which are the sub-causes? And one of the sub-causes is the cancer journey. You've got to suspect cancer. So who's going to suspect cancer? It's got to be the parents, right? The doctor can't go to your house and suspect cancer, or the community health worker who goes to your house and looks at the child. And then who makes a diagnosis? There are diagnostic components, and then access to treatment. And when HIV was first reaching epidemic stage around the world, in India, they had a very intense program of try to get people to get tested. And nobody wanted to be tested because it was stigmatizing. Sometimes you would even be, killed by your relatives for being, infected, or just all kinds of crazy things. And the program failed miserably. When they got the total cost of triple antiretroviral therapy to less than $100 per person per year, and when it was available by the government, so every diagnosed person got free treatment, suddenly everybody came for testing. You didn't have to do a come and get tested program. So sometimes starting at the end and saying, if you get diagnosed, you will get treated, now you have a reason to go get tested, right? If you get diagnosed and you're only going to get stigmatized and not treated, it's not really incentivizing. So it's no surprise that, fragmented health system, health beliefs and social factors, policies, and strengthening health system is the solution to a lot of these pieces of the chain. Because you can't really change where people live. You can't change their transportation, that they have to go through to get to the place. So I think we have to focus on what we can change. Here is the single cancer center. It looks like it's in the ocean. It's actually right here for this whole state. And this is 1,000 kilometers from here to here. And this is a state in the northeast of Brazil, one of the poor parts of Brazil. And they actually worked very hard to improve outcomes. And they got up to 65% cure rate. It should have been 80%. So they had a 15% gap. And part of that gap was patients coming late with these huge tumors, metastatic tumors. And they said, well, how can we get patients here earlier? And so we got to intervene at the community health worker level. So they train community health workers in all of these cities. And next to it is how far it is, 276 kilometers away, 244, 249. But literally their foundation paid their gas and their time to go all around here. And here's some of the classes of the community health workers. And they basically just added a one-day training about recognizing childhood cancer. And they made a nice book right here that they gave away free. And there it is, the role of the community health worker in early diagnosis of childhood cancer. So do you think this was a good idea, a bad idea, or a other? Who says good idea? Who says great idea? All right, bad idea. Other. No others? So what if the ophthalmologist then said, I'm getting patients with strabismus who are coming way late to my clinic. I need an eye recognition program. And they designed an eye training for community health workers, and they went to 50 places, trained all the community health workers, and they made a book. And the book could have been the role of the community health worker to diagnose eye problems in children. Good idea? Well, that's a multiple choice, yes or no. I don't. Comments?
I know this is a good idea based on what you were telling us last night. And you'll probably go into more detail about that, but it's a little bit more straightforward, perhaps, than looking for specific signs of cancer.
So like eye problems rather than cancer?
Yeah, I was going to say the same, and as well as just the fact it's going to affect more people. And so that community health group is going to have more effect on that population than the cancer, which is overall a rare occurrence.
I think it's a good idea, but it lacks some other steps forward. But it's the treatment, access to treatment, and That's the problem. I'm Brazilian, by the way. No, from Rio.
Yeah, so I was just imagining, what if every single piece of healthcare had its own book? Those poor community health workers would be spending 365 days a year in special training for one issue. And so the child cancer program, I think it did one thing that was incredibly important, more important than the book, more important than the content of the education, was this is the pediatric oncologist. He was there in person to do the training, and he gave his cell phone after the training, and everybody kept the book. The book has the cell phone in it. It's a cell phone that's covered by the doctor who does the consults for the day. And I think that cell phone is by far the most important thing, because people will say, oh, I feel a lump in the stomach. I remember something about that. I don't remember any details. Let's go find the phone number and call and find out. And so they answer the call right away, and then they say, oh, no, go to a pediatrician or do a CBC or come right now to us. And they've had... I don't know about the last 4 years of data, but in the first 2 years of the program, they had 92 children with cancer referred, but it was out of about 200 who were referred. And I said, well, that's only a 50%, should we work on their specificity? And they said, no, of course not, because the other 100 had other problems. One had tuberculosis, one had, so then they say, hey, good job recognizing a severe health problem in a child. Good job sending him to us at our request to see same-day service, and it turned out to be tuberculosis. And now here's your infection doctor, and here's the letter, and here's the treatment plan. And we already gave the first 2 weeks. Here's the rest of the plan. So I feel like the cell phone and the brain are the two key tools here. So what do you think about this? If I can only get you to discuss it, we can boost our stats. And so I think showing up and having people discuss the issue of childhood cancer, it also puts in your mind children can get cancer. And that idea is new for most people, that children even possibly can have cancer. So they probably had several unintended benefits of that program that turned out to be fundamental. And I think this is really nice that you guys have such a powerful education program, because you yourself will remember 95% of what you teach others. So teaching others is the most educational thing you can do for yourself, actually. So this was the baseline problem, most important baseline problem. Thank goodness there are tools to address it. Here's what they also did. Again, Recife, Brazil, same thing. They used a protocol from St. Jude, not because St. Jude recommended it, but because they came for a visit and photocopied the protocol, took it home, and used it. And that seems like a better idea than just guessing. But 32% cure with the St. Jude protocol that was curing 80% of people in Memphis, Tennessee. So what would you do about this? The very first system we talked about today was continuous quality improvement. So you identify a quality issue, and now what are you going to do? You got to figure out what is in that gap. And there's the oncologist and there's the psychologist who did this work. And this is headquarters right here of the NAC, which is you have to say it, the Núcleo of Apoyo of the Criança with Cancer, Child Cancer Charity. And all of this is the guest house, 120 apartments for the parent and the child. And then they noticed the patient would be sitting all day at the hospital to get physical therapy. And they thought, you're sitting all day with infected people, and we're going to have a worse problem with infection than we already have. So they put the physical therapy in the guest house, and then they put the dentist in the guest house. So the children will be playing, and then, it's your turn. So I thought that's terrifying. But physical therapy maybe is okay. And occupational therapy and the social worker. So why should you sit waiting in a hospital facility to see a social worker when you could put that here in the foundation? And free transportation and food. And their abandonment rate went from 16% to 1% to 0.5%, and now is 0%. So these interventions actually do work. How do we know? Because they used a systematic approach. First, they put the guest house, then they did the education, then they did a patient tracking system, then they did a food subsidy and a transportation subsidy, and next thing you know, they made it. And here's a patient tracking system, for example. This one is in Tagalog. Why? Because if you build an information system, why wouldn't you have multiple languages? Why wouldn't you be able to put your data in one language and take it out in another language in case you want to collaborate with someone in a different country? Of course you would be able to do that. And what's handy is, If you imagine using this system elsewhere, because you say, well, Recife, Brazil, that was a special case. You got a psychologist married to the oncologist, super convenient strategy. The government of Brazil is amazing, pays for all the chemotherapy, is covered by the government. So this is really a wonderful blessing. And then El Salvador, though, same thing, 12% abandonment down to 2%. So they also were able to make great progress. And you know what they did? Their first step they took? They actually went to Recife, Brazil, and said, how did you set it all up? How did you do it? You know, perfect. And then they copied as many things as they could. They have one social worker per 1,000 patient visits. So that's a busy social worker. So if you said, oh, I think the social worker should do a 30-minute training for all the patients. Well, that's 30,000 minutes. You know, that's a lot. So why do I say 12% to 2%? What is this doing? That's a 12% and a 2%. Did I give you new information? No, same numbers. What did I change? Visual, right, it's visual. And why do I pound on this horse? Because apparently repetition is also part of persuasion. If you hear something 5 times, you're more likely to believe it, even if it was false every time, right? So you can say, building a wall is a good idea. If you say it 5 times, all of us, not just Republicans, all of us believe it more. That's how it works. And so things that seem crazy, if you do it over and over, start to seem normal. And things that seem normal, if you do it over and over, start to seem good. And that's just the way we're wired. So we have to be trained in hypnosis, I guess, to defend ourselves. So involving everyone in publishing results, this is Catherine Lamb. She's actually my wife. And I know what you're thinking. He married a teenager. But it turns out her mother, who is in her mid-60s, in Canada, where they're from, you get a discount if you're a student or if you're over 65. And so she got on and paid the student fare to the bus driver. And he says, I need to see your student ID, because you look borderline like you're too old to be a student. And she said, no, I'm elderly. And he goes, what? Because she thought he was a 20-year-old. So I guess she's going to look like a teenager forever. But she discovered that people in the Philippines, where she lived for a while working on childhood cancer, had many ways to describe issues like lack of care retention, non-compliance, treatment abandonment. So all of these words had been used for abandonment. No-show. So no-show for some of us means I missed an appointment at a clinic. No-show for some other people meant I left and never came back. And my very favorite one is down here, run away. So it says the patient ran away, and I just picture, we're going to give you chemo. No thanks. So I like the term for this, the semantic chaos. So step 1 was to say, all of these terms are useful and good, but they need to be categorized. So incomplete treatment, that's I missed a dose of chemo, or I stopped for a week and came back, or I didn't swallow my pill that day, or I discontinued treatment because I relapsed and I'm on palliative care. That's not abandonment. That's a medical decision. So treatment abandonment or default is the only approved synonym. This is a specific thing. And here are the ways you can put this semantic chaos into order. And then here's a handy flow chart. If you're the data manager and you're supposed to categorize the issue, you can't improve what you don't measure. So if it's not categorized correctly, if you think everybody's running away, you might, do a handcuffing program so they can't run away. But if it's really abandonment, they need other things to make it work. And then some case examples. And these case examples actually also come from the tuberculosis literature, where abandonment of treatment leads to refractory tuberculosis and multi-drug resistance. And then we ended up getting married, and that's nice. So if you're thinking, maybe I could find love in pediatric oncology, it could be, right? It doesn't have to all be work. And the number one answer for why doing projects, it's said to have fun. What could be more fun than meeting your future spouse? Even the statisticians in the US never know how to treat abandonment because they never had this problem. So there was a thing called loss to follow-up, but loss to follow-up actually means I finished all my treatment and then I was lost. So loss to follow-up doesn't affect your cure rate at all. It just affects the information. So loss of follow-up is a research problem, not a patient outcome problem, not a survival problem, whereas abandonment happens during treatment. And if you have the abandonment-free survival here in blue, it's lower than the event-free survival. So even managing abandonment needs a specific strategy. And 100% of what we write becomes part of us. So that's an old paper, but I still remember the findings because my wife wrote it. So if we say, let's look back to Vietnam, Ho Chi Minh City, we had all this lack of diagnosis. They did a program and improved the diagnosis. But look at the blue here. Because what was the real goal? What was the objective? Was it to decrease a red histogram? Or was it to save that child's life? The cured is the saving their life part. So the lack of diagnosis went way down, but the cure rate only went up a little bit. Why? Because diagnosis is just the first step. If you get diagnosed, you could still get diagnosed incorrectly, I mean. So they say, yeah, you have cancer, but the wrong type, which means the wrong treatment, which means poor survival, or abandonment. So all of these other problems actually went up. Relapse went way up. Hardly anybody relapsed before because nobody got diagnosed, and the ones who did abandoned. And so increased relapse in this case is okay because more cure. Now we got to work on these other things. So these other things could include infection. And what can we do about death from infection? We need research to know what to do. And this was my research mentor that I met at the airport, actually. And I asked him, how many beers does it take? And he said, the trouble with my research is by the time you finish the project, you can't remember. So I was thinking, he needs an information system, right? He needs to log check another beer, you know, and the pounds going up. And you see that I'm following his pathway because I used to be thin, and, you know, but I have a database. So I'll be able to give you that answer in 20 years. So here's one type of research, which is bacterial growth. So the number one cause of death for children with cancer in this country is sepsis and septic shock. And how does that happen? If you get a bacteria into your bloodstream at time 0, and you have one organism, there's some bacteria that double every half hour. So half an hour later, you got 2 bacteria per microliter of blood. Another hour, and you've got 4. Another half hour. An hour later, you don't have 8, you have 16, because 2 half hours. 4 times 8 times 16. And then 256. And when you have 4,000 bacteria per microliter of blood, you get a fever. So when people say there's a golden hour between the fever and the first dose of antibiotic, if you have an immunocompromised patient, that hour is critical. And why is it critical? Don't ask me, look at it. Because 2 hours later, you go from fever to 65,000 bacteria and sepsis. 2 hours later, 1 million bacteria, septic shock. 2 hours later, 16 million bacteria and death. And so when the patient gets fever, what if everybody was asleep and it was at night and the fever is detected at 3 in the morning? You don't know if they've had the fever for 1 hour, 2 hours, 3 hours, 4 hours. So what if they already have 65,000 bacteria? Most parents don't recognize sepsis. You have to have some vital signs and some other stuff. So the golden hour is designed to try to catch everybody in these first 2 phases and prevent these next 2 phases. And why is that? Because these same rapidly doubling bacteria have lipopolysaccharide or endotoxin in their cell wall. And when you kill these bacteria, so now let's say this patient had 12 million bacteria. This is an error. I should have given this patient the same number of bacteria as the red one. Wouldn't that have been smarter? 16 million. Instead of inventing another number, distracting your brain. And now I've just distracted your brain again by calling your attention to the mistake. So don't do that. The free endotoxin, 400. And that's because bacteria are always growing, but some are dying spontaneously, releasing the endotoxin, that little... And notice the lipopolysaccharide, the endotoxin, it's the shape of dynamite because it's like an explosion inside the vasculature, causing vascular leak, hypotension, and multi-organ failure. And so if you treat this patient with their dose of antibiotic, which you should, within an hour or less, ideally half an hour, then 8 hours later, their blood culture is likely to be negative. They have no detectable bacteria. But the free endotoxin is way high because all of that bacteria is now just floating around as those little sticks of dynamite are floating free. And a whole bacteria doesn't cause vascular leak. It's the broken up bacteria, the endotoxin itself, that causes the vascular leak. And this is a patient that will die in every country. They've even tried a dialysis membrane that has an antibody to bind the endotoxin. So you run their blood through it as fast as you can and try to remove the endotoxin by an antibody binding it. Of course, this doesn't work at all because by the time you get the catheter hooked up and everything set, the multi-organ failure is too far along, and now you've got a catheter and a dialysis membrane adding to your problems. So this is, I think, pretty visual. Probably it needs to be even more visual and stuck on the wall at the ER, because many ERs say, oh, it's a fever, but they look okay. Go over there. But remember, looking okay, you look okay here, you look almost okay here. So you can look okay until you get 1 million bacteria. And some people look okay till even 1 million bacteria, you can look okay till you give the first dose of antibiotic. And all of us in oncology have had patients where they walked in, you gave the antibiotic, and they went septic within a very short time. And that's because of that lysis and release of that endotoxin. You could say it in Spanish. Why wouldn't you? Because you could do your study in El Salvador. And why wouldn't you? Because in El Salvador, they had 12% toxic death in induction for acute lymphoblastic leukemia. In this country, we have 0.5% toxic death. So they said, if you die in the first week, you're very unlikely to survive for 5 years. Though, the guy did call me and he said, weirdest thing happened. In the database, the patient is dead, but I saw him at the mall last week. What do I do for the analysis? Because he was picturing the survival curve is going down and now it's coming back up, And I said, well, I don't know, happy Easter or data error? So if you see the patient at the mall, go check the database and change that to alive. But they said, what is the delay? And they didn't just say how much time between the fever and the first antibiotic. They said how much time in the fever and deciding you're going to come to the hospital. And then what time did you leave your house? And what time did you arrive to the ER? And what time did you arrive to the ER? And what time did they give you the first dose of antibiotic? And within this purple are all the subcomponents. There are always subcomponents. And the transport time, cost, will the taxi even come to my unsafe neighborhood at night? Some neighborhoods, San Salvador is a very unsafe city, so they won't come there at night. So you got to walk to a place to get the taxi. And then the hospital, these green ones are hospital problems. The pharmacy, the prescription, the preparation. Do you have an IV to give the dose? So the system has to involve everyone. And the published results, this paper has helped so many people who have never been to El Salvador, who have never heard the El Salvadorans speak about their work. They read this paper and said, I can do this exact same thing. Because the decision time, how long should it take a parent of a child with cancer to decide, I've got fever and I'm going to go? What's the goal here, the target? 0.000 minutes. It's a policy, a system. Fever, go. Because my child could have bacteremia and could be about to die of septic shock. So I think it's nice to be curious, to be hungry. My child used to think he was a dog, which was super cute. And here are the emails that I used to send to people about how to adapt their chemotherapy protocol. Here is the PDF of the published paper. Nobody listens to this. Everybody listens to this. The words here are the same words here. The chemotherapy here is the same chemotherapy here. It's identical. But for some reason, this is unpersuasive and this is persuasive. I actually don't even understand that one, except maybe social validation. Like having the pretty woman reading your book. The social validation is other people thought this was interesting enough to publish it, and so it survived peer review, therefore it might be more credible, even if it's the same exact cast of characters and the same recommendation. So finally, the system to actively fight pride and selfishness. This turns out to be the most toxic thing in academic medicine. And the combination of pride and selfishness is like the worst thing for the human soul. And so after the Dilbert guy, my second favorite author is C.S. Lewis, and he wrote this book called The Screwtape Letters, which is amazing. How many of you have read this book? How many of you have read his Narnia books or heard of his or seen the movie? Because your kids made you. Yeah, so the Narnia books are great, but this one is amazing because it's two demons, and they're writing to each other about how to tempt their client. And so the junior demon is getting advice from his uncle about how to tempt his client, who's a human, of course. And it's fantastic because he said, try to make sure your clients, all of their virtues are distant and theoretical, but all of their vices are real and personal. So he said he can love humanity as long as he mistreats his mother. He can love social justice as long as he's unfair to his employees, specifically. And so the idea of getting all the virtue as close to the heart as possible. I have a friend who's a librarian, and she said, I love people, but I hate the public. And I thought, yeah, I could see that, this big line of complainers. So I was thinking, C.S. Lewis, probably should have worked on his persuasion game because half this room has not read his book yet. But maybe if he'd had somebody posing with his book, it would have been another way to get us to read it. I wrote one book, and you see that it was a loser from the title on out, right? And the reason I tell you this is because sometimes you get external support to remove your pride. And I got an envelope from Elsevier, the publisher of this book. Yeah, sucker for them, right? And it came in the mail. It was a full envelope, but it had the plastic window. And I saw through the plastic window that it was a piece of a check, that I could see like the edge of a check. So I thought, money. That's always good. And, you know, from Elsevier, I have no idea why, but I'm not going to complain if somebody sends me a check. So I opened it. It was a thick stack of reports. And this whole report was everything about the book: the online sales, the physical copy sales, the sales abroad, sales domestically. And so I was looking through this report trying to get the bottom line, and then I finally got to the final page, which was the actual book sales. 3 books, 2 domestically and 1 abroad. And my mother bought one, so that means there were a drunk person on Amazon and maybe 1 nephrologist. Or, maybe it was the nephrologist's mother, because my co-author was Kevin Finkel, a nephrologist. Yeah, so probably 2 mothers and some drunk person. Alexa, tell me about cancer and kidney. You know, and next thing you know. And so my chapter in this book was about tumor lysis syndrome, which is when you have a big tumor. It's just like when you kill the bacteria, it releases endotoxin. When you kill the tumor, it releases uric acid and phosphorus and other stuff and can kill the patient. And so my chapter was about this, and there's a pharma company, Sanofi, that makes an enzyme that protects you from tumor lysis syndrome. And I ran into one of the salespeople from Sanofi, and he said, "I read your book." And I said, "You're kidding, you're the 3rd one. I've been looking for you." And he goes, "Well, actually, I got it on eBay." I thought my mother betrayed me. So sometimes you don't have to actively fight. The fight will come right to your door in your mail. Oh, and the check, guess how much? 48 cents. So it turns out I get 16 cents per copy and the nephrologist gets 16 cents. So next time I'm going to write it alone, then I get a full $1, you know, and then maybe try to sell more. And now that with Alexa more universal, probably sales should go up with drinking on the rise. So what do you think, A or B? Okay, and whether it's dark or light, I think the key here is that systems are better than goals, and the system that we must all apply is to continuously improve the quality as we do our daily lives. So it's not to say I'm a quality specialist so I don't treat patients. I treat patients, therefore I must be a quality specialist. Or if I'm a quality specialist who does not treat patients, I'm doing this in support of those who do, right, to make them more effective. And focusing on 1 or 2 issues that I can do, I, Scott Howard, can do. Because I can't control what you're going to do. I'm trying to control it through persuasion, trying to convince you to use these techniques to be more effective in what you already want to do. And involving everyone and publishing the results so that everyone gets the benefits. So thank you very much for inviting me. I really, really appreciate it. And I see I ran it down to the wire, so ask your questions fast.
So thank you, Scott. Just, you know, what you've said, it feels like almost a boiling the ocean sort of thing. And I guess my question is, how do you, as a leader in this, decide where your effort is going to go from, you know, those 5-year blocks?
Yes, and so I really didn't want to boil the ocean. I wanted to show you the ocean so that each of us can boil 1 cup of water, but pick the right cup. And so for me, the first thing is, can I personally boil this cup? Is it the right cup for me? Because at the end, I'm not a neonatologist, so I am working on some neonatology projects, but I probably shouldn't be, because there are people doing that. So if I'm a neonatologist, I'm going to work on that, maybe in 1 country, 1 project, improving ventilator management in midterm preemies, something like this. So in my own case, I love education, but I thought developing nurse practitioners is something that nobody else was working on for low and middle income countries. And every time I bring up the idea, literally every time, it's wonderful, charming to see what happens. Predictable sequence. That's impossible. The doctors don't want it. The government will block you. The nurses probably will block you. And this list of problems is exactly what happened in this country in the 60s. The nurses didn't want it, the doctors didn't want it, the policy didn't want it, there was no mechanism. And here we are today, where in oncology at least, nurse practitioners are half the workforce, and probably the most important half, if we have to be honest. And so at the end, I thought that's something where I can work in an advocacy and specifically implementing projects to say, well, it worked in the Philippines, it worked in India, so using social validation to say, why can't it work in Myanmar if it worked there? So making a couple of pilot projects that work, I thought that's something that will be hugely impactful and that I personally can do. And being a doctor in a nursing school, I thought this is another way. It's very symbolic because people say nurses are not important. That's a common belief in low and middle income countries. And it used to be a common belief here. But to say what you work in a school of nursing, your boss is a nurse, then this is really great because then it reframes everything to say you bring the healthcare professional that the patient needs, not the one that you think is better. So that's me. But then in this room, I hope each of you is thinking about, for example, bilirubin lights for children who have jaundice. And so somebody in this room is working on that project, one place, one device, one study. I think that's the individual project is what saves lives, not the big picture is what hopefully helps you find your individual project.
It is 8:30. If you have any more questions, come to the front.
And these slides are yours for the taking. I hope you'll take them.